So I'm hoping everyone in the room understands how important returning to function is. We know from the research, this is where we get into level 1 research says that when we can get people more functional, when we get people moving again, as Heather talked about, we can help them out. If we're looking at trying to change people's pain and their sleep and their mood, as we heard is a good idea, well, one of the things that we know is that when we can get people to move, we can actually help them with each one of those things. When people can move better, they sleep better. When people move better, they feel better about themselves. It changes their thoughts, it changes their emotions. And so this has got to be a big, big part of what we do. And of course, I'm a physical therapist, so I'm pretty biased about this. I'm also a yoga therapist, and I see people changing there with functional things as well. But I want to try to give you a bit of an understanding about where we want to come from this. So the first thing I would like to point out is that people in pain know that they need to get more active. This is not a problem, but we seem to think that it is. We seem to have this idea that people don't know they should be more active, but they do, right? They hear it from us all the time. So if knowledge that exercise or movement is a good idea isn't the problem, we need to look at, well, what are? The first thing we would all find through the research is this idea of a fear avoidance. We know that's a big barrier to getting people better. But I'd like to take you back to this morning when you're listening to what Heather said. I'm hoping that you didn't notice any talk about fear avoidance there. What you heard was someone who endured the pain to get life done. And I think that we need to recognize that as much as some people have some fear avoidance around movement, what a lot of us do when pain persists is we just grit our teeth, suck it up, and we carry on until we cannot do it anymore. And unfortunately, this is not something that's going to help us get more active in the long run. It only helps us with getting things done now. So we need a different strategy for that. And as primary care practitioners, what we need to do is recognize when the person is showing this kind of I'm enduring the pain behavior. We're getting research now that says when people, their primary strategy for movement and exercise is enduring the pain, this does not help them get better. It's not a good long-term recovery strategy. We know there's lots of myths about pain. We heard this morning about this idea that pain equals damage. People have this idea, this linear connection that we can all blame on Rene Descartes for giving us that. We know there's myths about chronic pain. There's tons of them, but probably one of the biggest ones is that it will not get better. I don't mean cured, all better. I mean this idea that it is a chronic condition. So if it's a chronic condition, all that it can do is get worse. And you heard Heather say a couple times instead of chronic pain, she said persistent pain. And it's a good word for us to remember because sometimes if we think about it as chronic, in our mind, it's something that will not ever get better. And maybe by thinking about it as persistent, that might help us. Attitudes to recovery. Most people who have chronic pain do not have this positive attitude towards this is something that they can't do anything about. And we need to change that. And I think one of the other big things we're starting to recognize, although we've known it, but we haven't paid a lot of attention to it, is the treatment that we know that would be the most effective for long-term outcomes for people is movement. But the treatment causes more pain. Movement itself gives us an adverse effect of the pain. And so we need to figure out what we're going to do about that. How can we help a person around the idea that when they first move, it is likely to increase the pain? We've got to find the right way to tackle that. I'm going to try to help you with some of these things as we go towards the end. So we know as healthcare people that people need to move. But one of the troubles that we need to recognize is that we need to help people get back to moving again, back to function, back to more physical life, is we need to provide them with a consistent message about pain and about recovery, and we haven't done that yet. We need to provide them with a consistent message about persistent pain. We haven't done that either. What we've mostly been doing with people with chronic pain is we started with them when they had acute pain, and when they had acute pain, we told them that the pain was because of a damage to their body. And so for 3 months, we told them that the pain had everything to do with the fact that they damaged their body. And then the very next day, when we said the pain's now chronic, we shifted our story, right? We shifted into this story that it's not because of your body, it's a chronic pain condition, and that's psychosocial. And so this inconsistent message causes a lot of troubles for the people that we work with. And we need to figure out what we can do about this. And I'm going to try to give you some answers to that as well. And we have to give people this clear message that medical management helps, because it does. Medical management is really, really important for people who have intense, ongoing pain, but the self-management is also required, and I think we need to give that message right from the beginning. And then, of course, we need to say, well, if you're having trouble moving, we need to give you some guidance on how are you going to do that. Now, this is one of the things that we get a lot of people in pain to do. We ask them to ignore the pain. We ask people to distract themselves from the pain. Have you done this before? Yeah, get people to do things that take their mind off of it. And I would guess it's probably the most commonly prescribed pain self-management technique is distraction. And one of the things that we need to consider right off the bat is it working, right? If distraction was such a wonderful thing to do to help people get better down the road, to help them get back to function, it should be working because we tell people to do it all the time, and the nervous system tries to distract itself from the pain as well. But distraction is not a good long-term strategy, and we need to get that out of the way. How many of you see patients who say, I can do the movement, I can do the exercise, I can go to the gym and I do it, but I pay like stink afterwards? My guess is that a lot of those people pay like stink afterwards because they become masterful distractors. And what we actually need to do is get them to pay more attention to certain things, not less attention to certain things. So in acute pain, distraction works. If you sprain your ankle, you can just walk on your sore ankle and everything will be fine. You'll get better, right? You'll be able to restore the movement of your ankle and the pain will go away. But in chronic pain, this doesn't typically work. In chronic pain, the sucking it up, gritting your teeth mode just does not seem to work for most people getting better. So I point that out because I think this is one of the barriers to getting people better with function, is the idea that they're taking the wrong strategy. What they're trying to do is ignore the pain, and we need to find something different for them to do besides that. I'm sure you've all seen this as sort of an idea of pain as a biopsychosocial experience. There's pain in the middle, or the person in pain in the middle, and all of these things affect it. One of the other things that we need to understand is how much pain is affected by everything. When a person has an acute injury, we typically say that the pain is there because of some pathology or some physical problem that's going on. When it goes to chronic pain, then we start to talk about this. But even in acute pain, everything is going to be changed. If you work with people, and I know you all work with people who have chronic pain, they will all tell you that pain changes everything in their life. Right? Have you heard that before? It's sort of like the worst country western song that there is, right? It changes everything. Yeah. Last year, there was this fellow sitting in front of me, and he was telling me about how pain had changed everything in his life. He just started talking about it. He said, yeah, my wife drove away in my truck with my dog. I'm now smiling inappropriately. And he wasn't too happy with me until I explained to him this idea that this other patient had told me pain's like the worst country western song, and then we had a good rapport building kind of thing, right? But it's pain changes everything, but it does this right off the bat, right? Pain doesn't just change everything when it persists, it changes it right now, and we can see that from brain scans, how much it changes everything. And we need to start to understand that more and talk about it more, is that pain is a biopsychosocial experience all the way from when you initially have it into the chronic pain, because then we can give people a more consistent message. And then we can give them more, not only consistent message about what pain is, but what they should do about it. So, if you tell your patient a story in which the only reason for their pain is tissue damage, it's harder for that patient to understand when the pain doesn't resolve as expected. And then you say they need to get more active despite the pain. Because that first message they gave the person was, well, pain is there because your tissue was damaged, so you need to rest it, you need to take it easy. But now the pain has lasted a little bit longer and you switch the message over to the other way. Right? So maybe what we need to do is start off right away with saying that pain is not only related to the damage in your body, that pain is a biopsychosocial problem right from the beginning, and then we can provide a consistent message to people about pain. And if you're wondering how to do that, don't worry, when we get to the scripts, we're going to give you some ideas on how to do that. So you could say, and just say this in your mind right now, the best way to decrease your pain, so the person in front of you has got acute pain, they just injured themselves, or they just had surgery a week ago, and they're still having a lot of pain from it. What you could say to that patient in front of you is the best way to decrease your pain is to decrease stress in your life and start a daily practice of calm breathing and relaxation. Right? Because we know that the pain is going to wind up the stress system. We know even when the pain has only been there for a short time, and we know that if you can calm down those responses, get the person to breathe more calmly, get them to relax more, that is going to affect their pain. Because the pain that they're having isn't only due to the tissue damage. The strange thing for people with pain is that the longer you have pain, the better you can tolerate it. But at the same time the pain's persisting and you learn how to tolerate it better, your systems have been practicing protecting you. And if your systems have practiced protecting you longer and longer and longer, they're going to be better at it as time goes on. Which sounds inconsistent with we could tolerate it more, but we need to understand this, is the system's protective responses are getting powerful. If we're going to help this person to calm those down, it's going to take a lot of work. And it turns out that movement is one way that we can do this. And we need to understand that in the face of chronic pain, the system doesn't habituate anymore like it used to, right? If I walked up to one of you and I put my hand on your skin, on your shoulder, and we started to have a conversation, at first the nerves in your shoulder would get really excited by my hand being there. But if I didn't give you the heebie-jeebies, right, if I wasn't freaking out, what would happen is the nervous system would stop sending signals, right? That those A beta fibers in your skin would stop sending so many signals because nothing new's happening. The unfortunate thing is that in chronic pain, that does not happen. In chronic pain, the system is continuing to act like something dangerous is happening. It's not habituating. And so we need to keep that in mind when we're trying to get people to move better. We know that from pain science that when pain persists, there's this vicious cycle. You've all heard about that. But one of the things that we haven't really paid a lot of attention to, there are a lot of little vicious cycles that go on. So the pain itself changes the way you breathe, and that causes more pain. Or the pain itself causes muscle guarding, and that causes more pain. Or the pain, anxiety, pain. We've heard about these things. If you look at the first one, the top one here, we know that pain tends to make people breathe in a way where they blow off too much carbon dioxide, which causes respiratory alkalosis, which then turns up the autonomic nervous system and gives them more pain. So one of the things that we know then is if you could actually do that, if you could get people to breathe in a new way, what they could actually do is just with breathing, they could change the pH of their blood back towards normal, and that would give them less pain. Now, it would probably give them less muscle guarding and probably change a whole lot of things about them, and I'm going to come back to that because breathing is really important. You've probably all seen people with complex regional pain syndrome. I think you probably all agree this is a very, very hard thing to change. So Sumitani and group in 2007 did research starting on people who had CRPS one hand, so it was only in one of their upper arms or upper limbs. And what they did was they did a test with these people to see had it changed their body image, had it distorted their idea of sort of the space around their body. And so one of the tests that they did with people was to see where do the people think the midline of their body is. So think more sophisticated than this, but pretty much saying to the person, close your eyes, point to a spot at the level of your nose that's in the midline of your body. And if people had CRPS in this hand and they pointed, what they would do is they'd point like this. They would end up pointing more towards the side that they had pain. At the level of your belly button, point to a spot where this is the midline of your body, and the people would point over onto the other side of their body. So their brain had distorted their sort of visual spatial body image. So what they did was they measured how far it was off in each of these people, gave them prism goggles that put everything back. So if their visual spatial distortion was 13 degrees, they gave them prism goggles that brought back 13 degrees. And then they asked them to do hand tasks with both their hands, 90 minutes. So 90 consecutive minutes doing hand tasks, which nobody liked to do because everything's in the wrong spot. So that's sort of nauseating, and it hurts to move your hand if you have CRPS, of course. Anyway, so what they did was they were looking at, will this change pain? Can we change their distortion of their body image back towards normal? And what they found was that at the end of the first week, there was no change. At the end of the second week, there was no change. At the end of the third week, there was a little bit of change in some people, but at the end of the fourth week, there was this big shift. A lot of people were starting to feel that if they didn't have the goggles on and they said, where's the midline of your body, they would point back towards where the midline of the body, we would say, actually is. And what they found was that with those people, their pain was better too. So these things happened concurrently. Less pain, and the body distortion was going back towards normal. Now they wanted to see, well, how accurate really is this, or how much can we rely on this? So some of the people, they gave them prism goggles that distorted it back, and when they distorted it back with the prism goggles, it made their pain worse. So my point of this is, here's this person who's got pain. The pain has changed the way they perceive their body. They gave them an activity to do, which changed their perception of their body back towards normal, and when it went back towards normal, their pain got better. Well, we can do that with movement too. When we get people to move, one of the things that we get when we get people to move is they start to get those distortions that pain creates in our visual or in our body awareness and our body image. They can move back towards normal. So that's sort of more evidence of why this is important and the good things that can happen. Because often, I really want you to think about that, because most of the time what we think is the exercise is just going to make them more stronger, more flexible, more of those things. We're not thinking that exercise will make their pain better, but the exercise can make people's pain better too, because it can change those neuroplastic changes back towards normal. So the pain we feel all the time is always an integration of what's happening in our body, our thoughts, our emotions, our context, everything that's happening around us. Pain is always that, and we need to provide a consistent message around this all the time. And so what we always want to try to give people is this message is the best treatment for the pain is to work on your body and your nervous systems. Now before we get to that, just two other quick things before we get to one way we can try to change this is, one of the barriers that can come up is that you need to believe that pain is changeable. If you do not believe pain is changeable, it's going to be really hard for you to convince your patient that pain is changeable. If you want to experience the fact that pain is changeable, just go home tonight, grab yourself an ice cube, hold it into your hand, and change the pain. If you can't do it the first time, keep practicing and you will be able to do it, right? You hold that ice cube in your hand and it will give you pain. But if you just sit there and you breathe, or if you sit there and you do certain things, you'll be able to find that you can actually change that pain. Some people can change it by thinking warm. I'm just going to think my hand's warm, and sometimes that changes it. But there's a lot of different strategies we could use to change that pain experience. And we need to totally buy the idea that pain is changeable, because otherwise we're not going to give people the message that we need to give them. We also need to get this, is that people hear this all the time. Back to the first point. They know that movement is important, but they don't know how to do it. So we need to figure out, how can we tell people how to be more successful? So we're going to talk to you about breathing, and David's going to take you through a bit of a breathing practice. But before he does that, what I want to get you to understand is that the reason that I want you to get your patients to start to work on calm breathing is so that they can do it when they're trying to move. If your patients cannot breathe calmly at rest, in their very best place, how could they ever keep their nervous systems calm when they try to move or become more active? And if they cannot breathe calmly when they're trying to move or be active, the pain will be worse. We've got tons of science that says that. So what we need to do first, and what we can do in our clinical practices, and it's only going to take a couple minutes, is teach the patients we have whose pain is intense or persisting how to breathe calmly. We need to teach your nervous system. So this is us to the patient. We need to teach your nervous systems to be less protective when you move, and the best place to start is with some calm breathing or muscle relaxation. So this is the kind of message that we're hoping that you'll start to give some of your patients, or more of your patients. Not just the people who have persistent pain. You know those people at the beginning when it's in the acute stage, but the pain's really intense? Or it's in the acute stage and you're starting to see a lot of those yellow flags? Start this early. Don't wait until it's chronic to do what we should be doing from a biopsychosocial perspective. So we've done the box breathing, and just quickly review to you that the purpose of pain is about protection, and you all know this. It's not there to tell you what the problem is, where the problem is, or how bad it is. The purpose of pain is protection, and that's the way it works. The job of pain is to get us to stop or yield, and we need to provide treatment and guidance to help to shift these protective systems and responses to being less sensitive, or to wind it down.